So in today's CGR, we would be presenting a single case of giant left atrium, which is not very unusual finding in mitral valve disease, but this patient was symptomatic. So we'll, in a short time, discuss what we did, what others have done, and a little bit about review of literature. The other is a short series of pulmonary carcinoids, and we had 3 cases recently we operated. All 3 were slightly different than the other, and we had used different techniques to deal with them. So I will be dealing only with the surgical aspect of pulmonary carcinoid, and not the medical aspect or the whole treatment of pulmonary carcinoid as such. So let us start with large left atrium, which is sometimes also called as giant left atrium. And to begin with, to begin talking about left atrium, I would, in short, describe what is the giant left atrium and what its problem is. So normal LA size range between 28 to 40 to 37 millimeters in size. And it is the chamber which is located just behind the ascending aorta. So eyeball assessment is that left atrium should be at least the size of aorta, and if it is more than the size of aorta, it is enlarged. So if it is more than 40 millimeter in size, it is called large, enlarged left atrium. So then what comprise giant left atrium? So giant left atrium is this term was coined in 1849 by Hewitt, and it was initially considered that if on X-ray, if the atrium is reaching to the chest wall, it is called as giant left atrium, and then gradually this disease was treated more frequently, and more formal diagnosis of giant left atrium came into being. So then about a left atrial size which is between 60 and 100 millimeters was considered to be a giant left atrium. Now the criteria are if the size is more than 65 millimeter in any of the direction, because left atrium is almost a sphere, it is called as giant left atrium, and with it there is a particular entity where the left atrial wall indents between the left ventricle and the rest of the left atrium in the end of diastole, and this indentation should be or pouching inside these 2 chambers should be at least 30 millimeters, then it is called as a giant left atrium. So the problems of giant left atrium are it can compress the nearby structures, or it can cause formation of thrombus inside, and atrial fibrillation, obviously, because the wall become extremely thin and enlarged, and the circuits have to take long time to reach to atrioventricular node. So there will be re-entry of these circuits and atrial fibrillation ensues. So the incidence of giant left atrium in one of the Italian series, they have reviewed the literature and they have found it to be about 19%. So with this diagnosis, about 19% of mitral valve disease may have a giant left atrium. And there are different ways to address this problem while we are operating, and we'll dwell on this later on. So Willis Hurst, most of us would have seen his book in cardiology. He has presented in 2001 a nice article in in Circulation, which starts from his memories of 1940s when he joined as a resident, and they started seeing large left atrium and giant left atrium. And his opinion, which should be respected, but it has not been documented by the facts which we look for in modern medicine. is that giant left atrium usually have a very resilient and a compliant left atrium, and hence it's in these cases the increase of pulmonary artery pressure, or rather pulmonary edema, is very infrequent. This holds true to most of the cases, but there are cases where there is increase in pulmonary artery pressure even with giant left atrium if the disease progresses further. And in India, we have been seeing the disease in all spectrum of ages and duration. So we sometimes find this also. The other observation which he makes is giant left atrium, which we have also seen, most of us have also observed, is giant left atrium is a problem of mitral regurgitation rather than mitral stenosis. He even goes on to say that because of mitral regurgitation being the acute lesion in rheumatic carditis, one of the reason for atrium to dilate is involvement of this atrial wall by rheumatic carditis, pancarditis. But on sections, whenever these left atrial walls have been sent for sections and biopsies, Aschoff nodules were absent. There was haphazard fibrosis seen in these patients in the wall of left atrium. So why do left atrium dilate so much, even in case of mitral regurgitation? So if we go into pathophysiology of this, the left atrium is it works as a unit in terms of compliance with left ventricle. And if one of the chamber loses its compliance, the other chamber becomes non-compliant. Other chamber enlarges. So in cases of mitral regurgitation, it is the left ventricle which starts losing its compliance early, and the left atrium starts dilating. So this is one of the theory. The other theory which we have just discussed, the involvement of it by the disease process itself. And then once it starts enlarging, then it starts following the Laplace law, which says the tension is directly proportional to the pressure and the radius of the sphere, or the left atrium in this matter, and the thickness inversely proportional to the thickness of the atrial wall. So if the radius increases, the tension increases, the wall thickness goes down, it further increases, and this causes further increase in the size of left atrium. So this is about pathophysiology mostly, which is not known. Now, what is the surgical treatment of giant left atrium? Is in 1983, this was the first and a good article of about 40 patients with giant left atrium presented by Cavazo et al. And they have done, they have divided their treatment into three portions. One subset did not was not offered any surgery for left atrium enlargement. The other section was offered plication of left atrium in a particular manner, and the third section was given plication of left atrium in two axes. That is, one along the mitral valve, which is para-annular, and between the two pulmonary veins, the right and the left pulmonary veins. So they found that this is their diagnosis in all three cases, and these are the types with which they presented. BP is bronchopulmonary compression, and the other type is left ventricular compression. So you see that bronchopulmonary compression is all comprised of about 23 patients of these 40. So they found that there was high incidence of low cardiac output syndrome, and respiratory failure and hospital death amounting to about 40% in patients where left atrium was not, nothing was done to the left atrium. While para-annular plication was done, the percentages decreased, mortality decreased to 19%. And when in group C, when the para-annular and in between pulmonary artery plication was done, there was no incidence of low cardiac output that was observed. So we present a case of young male who presented with a diagnosis of rheumatic heart disease, severe MS with MR, and the problem, this is a usual case which we are confronted with in our OPD and during our surgery. But there was a change in quality of voice for 6 months, and there was loss of weight due to inability to ingest food. So he was not able to take food, and he had lost about 6 kgs of weight in 3 months. So that was quite something, and he had become quite thin because of that. And if we go by change in quality of voice, this is commonly known as Ortner syndrome, described in 1897, more than 100 years back, by Norbert, Austrian physician. And he in this now this Ortner syndrome has been expanded to compression by any cardiac mass or chamber externally of the left laryngeal, recurrent laryngeal nerve. Left recurrent laryngeal nerve has a long course around the arch, and that is where it gets compressed between, usually between the bronchus, left main bronchus, and the left atrium. That was the case in our patient. The other inability to ingest food is again because of compression by left atrium in the lower part of the esophagus, and this has been described as dysphagia megalatriensis or aortica. Dysphagia lusoria is the word which is kept reserved for appearance of right subclavian artery from descending thoracic aorta, which when crosses behind the esophagus, it causes compression and of esophagus and dysphagia hence. So we planned for a mitral valve replacement in this patient with a giant left atrium. So this is the X-ray of this patient, the PA view and the lateral view. In PA view, we can see it is almost reaching the right side of chest wall, and in lateral view we can see that it has crossed the spine posteriorly. So this is the echo report, and for your benefit I can read, which says that the left atrium is 170 into 120 millimeters. So this was quite a large left atrium with usual diagnosis of severe MS and MR. Left ventricular dimensions and function was normal. So this, when we went for operation, this is what we saw. The giant left atrium was seen, and it was not being captured full frame in transesophageal echocardiography. So this is the picture of giant left atrium once we open the pericardium. I hope you can see this arrow. So this is the aorta, this is the right ventricle, this deep blue structure is the right atrial appendage, or you can consider this as the right atrium. And this thing which is bulging in between the right atrium and aorta, which are supposed to be in close contact, this is the left atrium, which is enlarging between the superior vena cava and the aorta. So this was quite a huge atrium which was enlarging superiorly. It was also enlarged in other directions too, but this was the main reason why possibly the Ortner syndrome happened in this patient. Once he went on pump, this is a machine. This is a picture of heart-lung machine. This is this unit is oxygenator. So this is the reservoir of the oxygenator. Oxygenator is down below. So what happened is this is about 4 liters. Usually we run heart-lung machine in a normal person where we go on cardiopulmonary bypass at around 500 or 600 ml of level, but in this patient it was all full. It went up to 4000 ml. Some of the blood was removed, but otherwise it would have spilled from this reservoir. So what we did was, in this patient we used this device, hemofilter, ultra filter, and we filtered about 5 liters of water from this patient out before we uh, disconnected it from cardiopulmonary bypass after the operation. I hope that this runs, and it will, yeah. So this is the open left atrium through which we are seeing inside the left atrium. You can observe the thin character of the left atrial wall. You will see it better in few seconds. So what I'm trying to do is I'm trying to close the left atrial appendage. So these are deep sutures which are placed anteriorly. That is why the camera, the head camera is not capturing it properly. This tube which is passing across is the vent which sucks the blood, which is pooling in the left atrium while we are operating. The raised portion on this posterior wall of left atrium is the descending thoracic aorta. So this is all cavity of the left atrium. This is the pulmonary vein. The right pulmonary vein opening and the left pulmonary vein opening would be deep inside, just below the area of interest at this point of time, that is left atrium. So left atrial appendage. So left atrial appendage needs to be excluded from left atrium. That is the easiest thing, the first thing we should do. Then this is the starting of plication of left atrial wall. We use the method of plication because of thinness of the wall and the ease of doing this procedure, as well as this is the way we plicate. We take 2 or 3 stitches till the pulmonary artery of the both the sides come close to each other, and this amount of wall is plicated. The other benefit of plication is, once you plicate a structure which is spherical, you expect the other walls to be stretched inside, and so the atrium is reduced spherically rather than in one direction only. So in this case, we usually what I do is do plication between the pulmonary veins. In our cases, in this case, there was para-annular dilation also, but that para-annular dilation was dealt with plication of the left atrial appendage. In this case, we went right up to the superior wall of the left atrium, plicating from the base or the floor of the left atrium in between the pulmonary veins, and we reach the superior wall. And what we had seen is superior dilation of pulmonary atrium. Yeah, it's almost over. So this is what happened after we had reduced the left atrium, which was bulging in between the SVC. This is, now we can see, this is the superior vena cava stitch for putting the cannulas, and this is the aorta. So this is right atrium. So right atrium is trying to now come in close relation with the aorta. This is what happened. We measured that it is still around 80 millimeter in size, which is like half of 170 where we started with. The patient did well post-operatively, was extubated next morning, and he had improvement in his symptom of quality of voice, and he could eat normally, as he reported to us the very second day post-operatively, when we allowed him to speak and eat. So this is 3 months after the operation. The left atrial size is measured by echocardiography. Transthoracic is 46 millimeters into 100 millimeters. So this is what we have achieved by plication. This is our article in 2013 when we presented the effect of mitral valve replacement on left atrial size. Most of the surgeons believe that if you replace the mitral valve, it reduces the transmitral gradient and it reduces the pressure at which atrium works, and gradually these patients would improve, the left atrial size would improve. So in 116 patients which underwent mitral valve surgery, we followed them for about 40 months, were divided into two groups of 79 and 37 of less than 60 millimeter in size and more than 60 millimeter in size. And what we found that the RVSP was similar in the RVSP fell post-operatively and was similar pre-operatively also in both the groups. Left atrial size reduced considerably in both groups, more in patients in group 2 where the size was more than 60 millimeter. So we did some ROC curves on that, and we found that the atrial size reduced by about 28 millimeter, the curve on the right side, by 28 millimeters in average in all patients. And the appearance of atrial fibrillation was seen preoperatively if the size of left atrium was more than 41.7 millimeters. So this concept of reducing the size of the left atrium and expecting that the left atrium, the atrial fibrillation would disappear, according to our observation study, it was not possible, because that would be around 41.7 millimeter when left atrial fibrillations, when atrial fibrillation starts in these patients preoperatively. So we are, by any technique which we use, we are not going to reduce it below that. And moreover, we are not including any ablation technique for reducing the chances of atrial fibrillation. These are the methods with which have been used in past to reduce left atrium by different surgeons, and all these methods go with name of some of the surgeons. So these are the plication methods which we have just discussed. You do plication wherever then left atrium. Maybe you cut some pizza pieces of left atrium. You can what we can do is we can do, this is the method which was proposed by Seguicki, which did the spiral resection of the left atrium and then restitch the left atrium. And this is again technique which includes plication and left atrial resection. So there is one other interesting method of left atrial resection reduction, which is called as autotransplantation, or is called as partial transplantation, where the where the left atrium is reduced after the SVC, IVC, pulmonary artery and aorta is divided. The atrium, the mitral valve replacement can be done very easily in this patient, because you can turn the heart to your wish, and then the left atrium is divided, resected, and it is, all the chambers are reattached. This was done in 1999 with Lasana, and it was repeated in 2002 by Garcia Valerial series, which did almost similar thing, but they divided only SVC. So there are proponents who would like to do this method, but then there are flip side of this method, which is mortality. Because we are cutting vital structures and resuturing them, which most of us consider maybe overkill for this operation. I would now move to our second section of our presentation, which is pulmonary carcinoids. I will only be talking of surgical consideration, as I understand that in this gathering, there are many people who have better knowledge of pulmonary carcinoids than we can ever achieve as surgeons. So this is just an overview how you suspect a pulmonary neuroendocrine tumor, which pulmonary carcinoid is also called as neuroendocrine tumor. There are three classification of pulmonary carcinoid or neuroendocrine tumor. One is typical, atypical, or metastatic or carcinomatous variety, which can be a small cell lung cancer or large cell neuroendocrine cancer, carcinoma. And once you suspect pulmonary neuroendocrine tumor, then you follow a method with which you can diagnose them, and most important of them is CT chest and abdomen to see for any other ectopic tissues in abdomen or the lung mass itself. Then exclusion of MEN1 syndrome. There are biochemical screening methods like urine 5-hydroxy indole acetic acid estimation, serum cortisol and ACTH estimation, and very rarely growth hormone can also be effective. MRI and Dotanoc PET scan are very basically Dotanoc PET scan is considered the tool to diagnose the pulmonary carcinoids. Bronchoscopy should be done, and an EBUS biopsy can be done in patients where the lesion is central. Central means very close to the bronchus. And when the lesion is peripheral, that is in the lung, then the resection of the lung should be done. Now, before going for resection of the lung, a patient should be subjected to echocardiography and pulmonary function testing to decide on what kind of resection in the lung we are going to perform. Histopathology, if we have it before operation, is of extreme use because we can plan operation accordingly. In histopathology, the most important thing is finding out the number of mitotic cells and the Ki67 proliferation index. The number of mitotic cells if it is less than 2, then it is a in 2 millimeter square area on histopathology slide, then it is a typical carcinoid. Between 2 and 10 is atypical carcinoid, and more than 10 is considered the carcinomatous variety, which can metastasize easily. So it can present with a hormone-like symptom, carcinoid symptoms, and Cushing symptoms, and this is telling you about the medical therapy which can be offered to these patients, but I will leave this area. Cushing syndrome happens in about 1 to 6% of patients, and carcinoid syndrome happens in about 2 to 5% of patients who present with pulmonary carcinoids. So what are the recommendations on surgical practice? So when you are dealing with lung, the intention of surgeon is to save as much of lung function as possible, as the intention of the physician, the endocrinologist is. The carcinomatous variety of lung of pulmonary carcinoid usually is seen in older age group, and typical carcinoids are usually about 10 years younger than the metastatic variety. So so if the age advances, these considerations become even more valid, because we want to save the function of the lung as much as possible for a person to have a normal life after resection. So what is localized resection in these cases is we should go for lobectomy or segmentectomy whenever it is a peripheral carcinoid. And if it is a central carcinoid, means it is arising from the bronchus, then the option is like you can't take the whole bronchus out, because then we have to remove the whole lung. So if it is located in some of the segment of the bronchus or the lobe, lobectomy can be offered or a segmentectomy can be offered. But if it is in the main bronchus, then the sleeve resection of the bronchus with bronchoplastic technique should be used so that the lung is saved. And the other method we have already discussed for peripheral, it is better to go for lobectomy or a segmental resection. But when the left ventricle, when the function of the lung is not good, then resection, local resection is also a preferred method. Local resection would also depend on the kind of tumor which you have got. So if there is a diagnosis with us, histopathological diagnosis with us before we operate, if it is possible, then we can plan the lymph node dissection along with it also, because if there are more mitotic figure and we expect it to metastasize, then dissection of the lymph node is expected from surgeon to be done at 6 stations, and 3 stations should be at least in mediastinum, with 1 station at subcarinal area. So this is the best or the good practice for these kinds of this kind of tumor. So first case which we encountered recently was a bronchial carcinoid, and this was a young girl who did not show in cardiothoracic surgery. It was seen by pediatric surgeons, and she had the history of dyspnea, chest pain, cough, low-grade fever. Now these are typical findings of a pulmonary carcinoid when it is centrally located. So these symptoms were recurrent for last 2 years, and examination revealed that the breath sound on the right side was almost absent. So further investigation revealed that there was a bronchial carcinoid, and it was it was in the main bronchus. It was almost reaching the carina and going into indenting inside the carina. So the pediatric surgery consultant, Dr. Ankur Mandelia, contacted us because there was a concern about this tumor, whether something can be done about it. Because if we go for resection of this lung, even if we go for bronchoplastic technique, was not possible. The lung was already getting destroyed. The peripheral lung tissue was not good. It was involving almost all of the bronchus. Down to the lobar bronchus, and the only option, the best option which the child had at that point of time was pneumonectomy. Pneumonectomy was also like considered difficult, because if it is going to the trachea or the bronchus of the other side, then possibly we would have to repair the trachea at the same point also. So we took Dr. Amit Kesri also into loop in this patient, and then we proceeded. Then we went along with the operation in pediatric surgery operation theater itself, and this is the resected specimen of the lung, which is showing carcinoid inside the right main bronchus. Now, if we're talking of surgical consideration in this case, this was a very hard tumor. The lung had become very solid. It was not even, obviously it was expected that it would not even decrease in size as we go into isolated left side ventilation during operation. It had become almost solid structure. It was very adherent to the medial side, which is medial side of the chest wall, that is where the heart is. So the pulmonary veins were very close to this mass, and it was difficult to rotate this mass and see the pulmonary veins for division to complete the pneumonectomy. So what we did was we used the intrapericardial technique for dividing the pulmonary artery first. So we opened the pericardium, went inside, divided the right pulmonary artery, and then divided the left upper pulmonary vein. And then we use it gave us some space and some confidence, as the vascularity of the lung would have gone down. Then we completed the dissection of the lung medially, and then divided the left lower pulmonary vein in the left in the inferior pulmonary ligament, and we pulled this tumor back after resection, and we could find about centimeter of right main bronchus which was free, and this tumor was seen to be not involving the bronchus of the other side or the trachea, and this was removed successfully. The patient, I believe, as reported, is doing well. This is the second case, which was a young lady who presented, who was referred to us from endocrinology department with Cushing syndrome. She was on diagnosed and was on evaluation for pulmonary carcinoid, and everything was positive. She was referred to us for favor of surgery. This is what it looked like in first surgery. There were two places where the Dotanex scan was lighting up. One was the right lower lobe, and other was at the right hilum. So there was something in the right hilum, and there was a mass in the left lower lobe peripherally. So this patient presented with Cushing syndrome and did not have much of pulmonary symptoms. So we went ahead and we resected or did lobectomy, right lower lobectomy in this case. So this is after right lower lobectomy, the patient did not improve biochemically, neither did there was some improvement in physical condition of hers. The muscle power had improved when I saw her next time, about 3 months, 4 months later. And by that time, we had decided that our operation has failed. We have been unsuccessful in removing the right hilar mass. So a CT scan was again done, and Dotanac scan was done, which showed uptake of right hilar mass in the right hilum. This time we went down, we did some reconstruction with radiologists. Dr. Zafar helped us in that, and we saw this mass very keenly. We then observed that this mass was not actually present in the hilum. It was about a centimeter deeper in the hilum, and it was where the bifurcation of the pulmonary artery was present. Now we are left with a situation where we have to go for a reoperation. We have already removed the right lower lobe. She is a young lady, and the next possibility was removing the complete left side of lung if we fail to find this mass. So this was the right lower lobe biopsy, and it showed a neuroendocrine tumor, typical carcinoid, and peripheral mass. And the hilar mass had no evidence of malignancy. Obviously, we missed whatever was there. So this is a short video of what we tried to do. So this is a harmonic scalpel ultrasonic energy. We started dissecting because we were dissecting over vessel, and we were also concerned that while dissecting the lung, which I have never done before, over the pulmonary arteries, we may injure the pulmonary artery. But we started dissecting, and as we were told by radiologists that this mass, which is about a centimeter, is present on the bifurcation, artery bifurcation, about 1 centimeter, 1.25 centimeter deeper in the lung tissue. So we started removing whatever mass in whichever bifurcation we found, because we were not confident, and there is not enough experience with me of operating these cases. So this is the right upper lobe. Rest of the lobe has been removed. This is the pulmonary vein, which is draining into left atrium and has been dissected. Pulmonary artery can be seen jumping there. So this is our area of interest. We had to clean this pulmonary artery going into the lung tissue, and removing, we were expected to remove a mass which was there. This is echocardiography probe, transthoracic echocardiography probe. When we had removed one mass, which we considered that it may be the mass of our area of our interest, but we were not confident because we had a failed operation on our past. So we tried to find out this mass by echocardiography. So at this point of time, you are seeing these drips because I am watching whatever I could understood of echocardiography of this mass. So we decided that wherever this probe was kept, that mass was possibly appearing like the mass which was described on CT scan, and we should definitely take out that mass. So this is a poor man's way of finding out on operating table what should be removed if you are in dilemma. Better ways are use of hybrid operation theater. See this pulmonary artery which is dividing. So we have taken out the mass from that division. Now we are trying to take the mass out from this lower division. So this is the mass which is in interest. All these masses were, this is in my pickup, the mass which I am trying to remove. All these masses were blackish in color, which were there was some brown tissue here. I don't know whether this brown tissue was what we were looking for, but this was the mass of interest. So we removed three masses from, these are the bifurcations of pulmonary artery which can be seen. All are bare, no tissue is available there because we failed to recognize the tumor. So the next best thing was take out all the masses which were present in bifurcations, and we traced the pulmonary artery right up to its division where it went for lower lobe. So lucky for us, one of the masses which we had removed found a typical carcinoid, and this patient improved biochemically post-operative. So in the previous case, we did not want to complete the removal of the whole of the right lung. Now this is Cushing's disease, again referred to us from endocrinology department, 1 centimeter lesion in right lung. And it was very close, it was in the middle lobe and very close to the surface of the heart, which was about 1 millimeter in depth from the surface of the pleura, visceral pleura. Dotanac scan, however, was negative. Biopsy was done, and it was found to be a neuroendocrine tumor, a typical carcinoid. So this is the tumor, and the halo around it is possibly spillage of blood which happened during biopsy. So this was close to vein. So how do we identify this kind of tumor? If we have to do local resection, I try to identify the surgical points which won't change once this lung reduces in volume and decompresses. So the one thing is these fissures, the horizontal and the oblique fissures between which the middle lobe is situated. This is the bronchus which is leading to the mass. So we know there is some bronchus which will lead us to the mass, middle lobe bronchus. So we would chase that. This is the kind of mass which was very close, about 1 millimeter or maybe less from the parietal pleura, and there was a vein which was located, vessels which were located very close to it. Our first intention was to do a resection, wedge resection of this mass, or maybe a resection like this between the oblique fissure and the horizontal fissure, so that even the middle lobe could be saved, as this is a typical carcinoid. So what we did was we went ahead and we again did not find any tumor, failed to find any tumor, palpate any tumor. So we did a right middle lobectomy. So after completion of lobectomy, the patient has biochemically improved, but the specimen is yet under process of finding this tumor. So with this, I complete my presentation. Thank you very much.